Good afternoon, everyone. Thank you for joining us today. My name is Fanyi Su, and I'm a research associate at Manchester Centre for Health Economics. Together with Rachel, we are very delighted to present our recent systematic review on the economic evaluations of interventions for self-harm and suicide prevention. This work was conducted under the Greater Manchester Patient Safety Research Collaboration, and we will walk you through our findings and the potential implications for both research and practice. So firstly, we're going to do a bit of introduction about the condition of our interest, which is self-harm and suicide. So they represent major public health challenges. We see at least 700,000 suicides per year globally. And in the UK alone, over 200,000 people present to emergency departments annually for self-harm, and about 1 in 5 of them will repeat within a year. These behaviors carry a huge economic burden, not just in direct healthcare expenses, estimated at around 130 million annually in England, but also indirect costs like loss of productivity and other societal impacts. So these evidence suggests that each attempt of suicide can incur substantial cost, which further strengthen the need for effective and cost-effective interventions. Even though some clinical reviews show that certain interventions can indeed reduce suicide or self-harm, we still need to know whether these interventions are affordable and whether they represent good value for money. So that's why we need to bring in health economic evaluations for this condition. Healthcare budgets are always limited, so decision makers may want to know the evidence that whether an intervention is both effective and cost-effective, and it is crucial for prioritizing interventions and to save money. Before this review, the most recent and comprehensive review on the similar topic of economic evaluations of self-harm or suicide prevention was published in 2018 by Madison and colleagues. They covered studies up to 2016, and since then, new interventions have developed, and the methodologies in health economics have evolved. We also have ongoing work within the GM PSRC in clinical effectiveness reviews. So now it seems to be the perfect time to update and extend the evidence base. Our review addresses the past 8 years of studies to capture the latest findings and techniques being used. So we followed a systematic approach and using a PICO kind of framework to define the review question. We focus on adults, whether they've had suicide or self-harm attempts before, or just general population. We include any non-medical intervention that aim to prevent or reduce self-harm or suicidal behavior. The outcomes of interest in this review were both cost and economic effectiveness. We searched databases from the beginning of 2016 to the end of 2023 using various quality assessment tools like CHEERS for the reporting quality of economic evaluations and QHAS for methodological quality, Consort for the quality of reporting for RCT evidence, and ADVISH for model validation. So this is the result of our research. We initially identified a large number of potential papers from the databases, but only 27 met our full inclusion criteria as complete economic evaluations. These studies range from trial-based analysis to more complex model-based evaluations. The variety of the study designs underscore how this field actually are changing. Some of these interventions are tested in clinical trials. Some of them rely on the modeling to project the kind of costs and outcomes over a longer horizon. So one trend we observe is a growing reliance on modeling techniques. So early papers before 2016, which is the end date of the last previous review, they often presented with trial-based analysis, and more recent ones have moved to decision models like Markov model or more hybrid decision tree and Markov model mixed together to capture the kind of long-term course of self-harm risk and repeated nature of suicidal behavior. This shift suggests a recognition that these outcomes mentioned before often extended far beyond a single trial's timeframe. In terms of the studies characteristics, most of them focus on individual known to be at high risk, often those who've been recently discharged or with established severe mental health diagnosis. The interventions that's been evaluated also included a wide range of approaches like cognitive behavior therapy, known as CBT, and dialectical behavior therapy, known as DBT, and other post-discharge management like postcard or phone calls, as well as e-learning tools for training. The interventions also spanned across multiple settings, primary care, inpatient care, and outpatient care. Some of them are actually cross healthcare settings. They all reflect how self-harm can occur across different healthcare service providers. In terms of the design of the models of the included studies, we noted considerable heterogeneity in terms of perspective, time horizon, how they actually designed the model. So about half of them took a healthcare perspective, and the others tried to capture a broader societal impact, like the productivity loss or the burden of care. Time horizons ranged from very short, 6 weeks, to lifetime or 50 years. Some studies, particularly those with lifetime horizon, they use Markov model or combined decision trees to capture the repeated episode of self-harm. A crucial point is how they classify death in their Markov model. We noticed some studies specifically modeled suicide mortality, and others just categorized mortality as in a general health states. So this is an example of estimating the long-term cost effectiveness in primary care. This is a study conducted by Liebenbaum and colleagues in 2020. It's a Canadian study that combined a public awareness campaign with training for primary care physicians in hope to reduce the suicidal behavior in general population. By applying a decision analytic model with tunnel health states, which is shown on the right-hand side of the slide, they were able to capture the increased risk of reattempt of suicide in the first 5 years after one attempt. They actually sourced the data through communication with clinical expert and got suggestion and refined the model. So this example also highlights how communication with clinical experts and other stakeholders can better understand the natural history of the condition for these models. Across the 27 studies that's been included, some reported cost per QALY, about 12, and the other 15 just reported cost per event. That can be cost per self-harm event prevented. several interventions like there's post-discharge management, help sheet, and some brief aftercare. The results shows that they're both cheaper and more effective compared with usual care. Others, like some certain forms of DBT, were cost effective but not cost saving. And for some intervention, like the residential DBT or a risk assessment over the general population, were found not to be cost effective. One thing I want to note here is that it is important that these findings can shift dramatically when we change the model's time horizon, settings, and analytical perspectives. And then moving to the quality of the studies that's been included. To assess the study quality, we use various checklists. Overall, the quality of reporting and methodology were reasonably high in these included studies, especially for model-based studies, likely because they must detail their assumptions to better explain the model. However, the consort checklist we use to looking at the quality of the RCT's reporting, review some gaps. For example, some of them just didn't report their power calculation or how blinding was managed, which can introduce potential bias in the future. Additionally, the model validation, which is QHAS, that's the tool we use to check for the model validation. So among all the studies, they remain quite weak in terms of validation of their model. Many modeling studies, they just include limited external validation or sensitivity testing to confirm the reliability of how they build this whole thing. So that's gonna be the last slide. We've now updated the evidence for economic evaluations in self-harm and suicide prevention. A key theme is the move away from trial-based evaluation to more of a mix of modeling and trial-based study. And these kind of models are attempts to follow patients over a longer term. Our review suggests that many interventions, especially some brief post-discharge follow-up or structured therapy, appear to offer good value, but there remain methodological challenges. For example, we need to better model, we need to better validate the model, for example, especially when the models are not open accessible, and to incorporate more consistent involvement of patients and experts in shaping how the disease progressed. One example is the Liebenbaum study, is how the risk is modeled in a study, and better understanding of the natural progression. The other thing we noticed that most of the models are not open access. So one of the recommendation we want to make here is greater transparency in publishing model so that the results are replicable. Yes, that's everything. Thanks for listening.
Thanks, Fanyi. A whistle-stop tour through what has been quite a long and complex piece of work. Has anybody got any questions? I can't see the chat, so I'm just going to look in the chat, see if I've missed any questions. I can't see any questions in the chat. Richard, you've got your hand up.
Yes, thanks a lot, Fanyi. I guess the first question is just for my own personal benefit, because I'm on a trial of self-harm, and I'm going to be building an economic model in the next year. So when do you expect your results to be published? And if they're not going to be soon, would it be possible to sort of access some pre-published results, or just a list of the studies that you've included that might be very useful for me? And then a second sort of more methodological question, I guess, was did you look at sort of, so I understand why you group self-harm and suicide together, because you get quite limited numbers of studies otherwise in terms of economic modelling, but there are some sort of distinctions. So not all people that self-harm will necessarily be on the same scale as sort of a suicide attempt, and it might be sort of a behavioural action rather than anything to do with wanting to commit suicide. So did you look at sort of those groups separately, or were you able to?
Yeah, I think I'm going to start with answering the second question. Yes, we did present the results in the summary table and give them a tag to see whether they are suicide. The outcome actually to reduce suicide or to reduce self-harm. So not necessarily through the analysis of the results that we extracted. We did not provide a kind of a comparison between the models that evaluate suicide or self-harm, but that information is included in the summary table. Yeah. And for the first question, I think, Rachel, what do you think?
So Fanyi's actually quite advanced with drafting the paper for submission. But I think, yeah, so obviously we're looking to submit this to a journal quite soon. And we've got to the point where we've stopped looking at the papers in quite so much detail, and now we're sort of stepping back and thinking about it. So that's why we wanted to bring it to this group to get some sort of broader ideas. So that's it's good, that question there, Richard. So I think that I think once we've submitted it to a journal, I don't see why we can't let you have a look at it.
Thank you, that would be great.
I think we've got Manoj, and also we'd be quite interested to hear about your intervention to reduce self-harm as well, because it's good to know that there's some overlap. And obviously the theme here at Manchester, there's a big theme led by Nav Kapoor and Roger Webb, which is around self-harm and suicide and trying to reduce both of those. But as you rightly said, you know, they are sometimes overlapping, but not the same in terms of obviously in behaviours, and obviously self-harm's a very wide-ranging set of behaviours. So we're linking in with a broader umbrella review that they're just finishing, that Leah Quinlavan is just finishing off, and it's massive, this umbrella review of effectiveness studies. So we've sort of been linking in with work that they're doing. So this is sort of the economic evaluations to complement their clinical evaluation work. But thanks for the question about looking at the two things separately. I think that's really helpful. Manoj.
Interesting presentation, Fanyi. I'm just going to ask a general question. So when we talk about interventions nowadays, I presume we're looking at digital interventions, but then the inequalities in accessing such, that also causes a problem. And I've been involved in a study because when my sister first fell ill, so that's 37 years ago, she did actually make an attempt on her life. So I've been involved in a suicide prevention study with Professor Diane Vepper at Bradford before she left for New Zealand. And she was all for all these digital interventions, but the evidence is they're sort of 50-50 accepted, and there's still so many that are not happy with receiving advice, information, guidance via a smartphone and wearable watches, for example. So general question I'm asking is, what form are these interventions, and do we allow for the health inequalities they might pose because they're digital?
So if I remember that right, there's only two interventions that's kind of can be characterized as digital intervention of the included studies. So I think that is a very interesting point, because we can take a look at umbrella review that's undergoing and see how many of the digital interventions that's been studied in terms of clinical effectiveness, because there's a gap in between the economic evidence for digital interventions. There's only 2 out of 27. So that's a very interesting point we can make in the discussion, because it's very few study looking at it. And I don't think they've actually looking at the access to the interventions, because one of the digital intervention is an e-learning intervention for physicians, actually. It's not necessarily for patients. It's looking at how a kind of e-learning platform for the physicians to better understand the guidance, the national guidance, and to follow the guidance would then impact the kind of suicide rate or self-harm rate of the patient of their area. So that's a very interesting question to look at, actually. That's understudied of the studies been included.
Great question. Thanks, Manoj. Really, really helpful question. Pearl.
Oh, hi. Thank you. That's a very interesting presentation. I'm just wondering, firstly, what's the rationale of only including adults? Because many self-harm started when people are teenagers, or children. Yeah, so that's my first question. And second point is that talking about the difference, group of people, self-harm and suicide. Because women are more likely to self-harm, but then males are more likely to die by suicide. So I'm just wondering, I don't know whether there's like a different economic effect between male and females. You see what I mean?
Yes, thanks for your question.
Economic effectiveness, between male and females, like.
Yeah, it's actually a new thing for me. I've never come across literature about this, but it's interesting. No, I don't think any of the studies included compare a female and male difference in terms of the cost effectiveness of the interventions of interest. Sorry, your first question was regarding why we don't include children or young adults.
Yeah.
Yes, that's a very good question, because we had a thought about it of the published reviews of a similar kind of a topic, not necessarily the same kind of intervention or conditions that we're looking at. Sometimes they include a broader range of people in terms of age. But what we're of our concern is that we mainly want to focus on the interventions in the healthcare setting, and a lot of those interventions for like children are school-based interventions, and that is a bit of out of the focus of our study. So in the end, we decide to only focus on adults as our target population of interest.
Okay, great. Thank you. Thanks.
So there's a question from Chris in the chat. Do you want to read it, Chris, rather than me read it out?
So it's a question from Chris asking.
Yeah, I think he's.
Yeah, sorry, I couldn't find the microphone. Yeah, so it's actually just been answered a little bit, because I missed a bit where you were focusing on adults and the shift focused on adolescents. So it's probably not really applicable then. But it was the reason I wanted to bring it up was we did something a little bit different and I can't claim credit for this because I wasn't part of the original team, and whoever thought of this was a genius, and whoever got it through the review process, pushed it through, was a genius. I don't know who it was, but it was sadly the Burst project originally. But we had a trial-based self-harm intervention that looked at 18 months, and then everything was published on that. But they'd also got this kind of extension where we had permission, and we asked permission from the patients themselves whether we could follow their HES, the routine data, for a further 5 years, which they did. And when that was available, there was a few of us were reawakened. The patients were never disturbed again. Of course, the majority of the research team weren't. We were just able to update the biggest driver of costs using the kind of HES data sort of 5 years on to get that longer term perspective, which I've never seen done before. And I thought it was really quite a novel novel, low-cost thing to do. That's a great idea. And like I said, I can't claim any make any claim to that at all.
Wow, that would be really interesting just to see those data, because I think one of the things that's been really interesting at looking at this is how the area has moved quite a lot from doing within trial analyses, which from my experience of working in mental health is a very, a lot of the studies are within trial, and there's not a lot of extrapolation to long-term outcomes. Which is interesting when you come from other disease areas where that extrapolation for longer term outcomes is much more common. And then to see this sort of change in approach sort of recently, and then also to see how different some of the models are and how they model out some of these effects. And I know that, so obviously if you've got long-term data, I know that Pearl has worked in this area and she's looked at the routine data in this area sort of over the longer term to populate sort of what's going on. So some of the earlier models were looking at sort of, just simple Markov models just tagged on to the end of a trial with a state for, alive and dead almost. But actually, if somebody's attempted suicide, then their probability of reattempting is quite high. And so so what the study that Fanyi highlighted had this sort of tunnel state in there. We didn't see anything more sophisticated, did we, Fanyi? There was no sort of patient level simulation or anything like that, but it looks as though there may be the data to support more sort of sophisticated models. But yeah, I mean, that type of longer term impact is something that's lacking quite a lot in these types of studies of looking at how people, are further down the line. Manoj and then Richard.
Fanyi, you mentioned direct cost. Obviously, there are indirect costs when somebody makes an attempt on their lives. So I'm thinking, do these studies include indirect costs to family members, carers, and the burden placed on family members? Like, say, a wife might give up work to look after her husband because he's very susceptible to taking or making attempts on his life in the next 6 months, a year, or whatever. So are these indirect costs included, or is it just the person that's made an attempt on their lives?
Yes. So I think you're talking about more likely a spillover effect of the intervention. So it's an extra benefit you probably get of reducing suicide or self-harm. That is very interesting, because I'm personally very interested in this area about a spillover effect of certain intervention targeting a mental health condition. I'd like to separate into two questions, actually. So one is what they claim, and the other thing is what they actually did. One thing is that a lot of studies, they claim that they actually include a wider indirect cost in the studies, but in the end, that's not true. It's just a partial societal perspective that they take. So, but how partial it can be, it varies between studies. So not necessarily the burden of the care that's included, but some studies, they just include a kind of loss of productivity. That's most commonly included in a study claiming have a societal perspective. And of those ones who actually did have a societal perspective, I think there are two trial-based analyses. They collect the kind of a chaos burden alongside trial, and that make that kind of data available in doing the analysis. But of those studies using modeling, they're model-based. I can't remember, but I agree with you. That's something that's quite important, especially for interventions trying to prevent suicide and self-harm, because there's the other review, actually. I can send it to you later. It's really looking at the impact of suicide on people, on family members, and on their next generations, like their children's, their grandchildren's. So I guess that's the kind of similar things as you just mentioned. Yeah.
A bit of work to do in that area, I think.
Fanny, just one quick point. It'd be very difficult to measure stigma involved in suicide and the impact and implication for whole families, because that is what would happen in Indian family. It's certainly seen as a no-no. If somebody takes their own life, the whole family is isolated. Nobody wants to know.
Yeah, really good point. There's a lot that to explore in this area. Richard, you've got your hand up.
Yeah, just sort of a minor question, really. Did you find any examples of models or anything like that where they sort of tried to disentangle sort of mental health related outcomes from sort of your interventions like your CBT and the sort of behavioural outcomes? So I guess what I'm trying to get at is what we were thinking of is you can have a sort of a state for self-harm, and whether people are self-harming or not self-harming, or whether they're dead, I guess would be a very simple Markov model. Were there any sort of differentiations between people that got like sort of short-term mental health benefits? I guess it could go into sort of a hybrid design with a decision tree. But yeah, did you see many examples of that, or were they just fairly simple models in general?
Sorry, I don't think I catch up with you very well.
I think what you mean is, so like looking at whether they improve things like a PAN score or something, as well as, so it's not just about the incidence of self-harm, for example, or attempted suicide.
Yeah, I guess, I've probably not explained this very well. What I'm trying to get at is, I guess with sort of mental health interventions, you usually get a sort of very short-term benefit over the sort of 6 months on your let's say it's an EQ5D score. So over that 6 months, you could have mental health benefits plus also benefits in terms of reducing your self-harm behaviour, for example. I would expect the effects on sort of self-harm behaviours to be longer lasting than the mental health benefits. So I don't know whether anyone had tried to sort of disentangle that within like an economic model structure, or even thought about it. That was what. Is that a bit clearer?
Yes. Yes, I think there are some models out there that they do use different measurements in the end, for short term and long term, but they didn't really point it out the difference or make any analysis out of these two. But yes, I think it's very important for the short term and long term both to incorporate in the model. Yeah.
Okay, thank you.
Okay. Has anybody got any more questions for Fanyi? Gabriel's got his hand up.
Hello. Pretty good work, Fanyi. Thank you. So I was going to, well, firstly, I was going to ask exactly the same question as Richard, actually, in that the angle I was thinking of it from is that presumably in order to be in a position in life where self-harming behaviours and or attempts at suicide are seen as options by people, their quality of life in and of itself is unlikely to be perfect to start with. And some of the interventions here are targeted in ways that you would expect to have an impact on quality of life, even if they had no impact on self-harming and suicidal behaviours. Or they could have impact on those behaviours, but not on quality of life. And like Richard, I thought it'd be interesting to try and unpick those if that's possible. The other thing that that I was going to say is you started, well, you mentioned briefly how the models deal with death within their time horizons, and I guess that is linked to the same problem that I was thinking about, in that, well, if you are going to capture the qualities you gain from preventing someone dying by suicide, then obviously you need a lifetime horizon to your model in some way. That doesn't necessarily mean you have to have a model turning over for the full lifetime. You can make some assumptions about the amount of qualities you save along the way. And so as a first question, it'd be interesting to know how different models have done that. But then the second one is the second question is more related to that issue of how quality of life over time may be tied up with effective intervention. So if you're gonna introduce an intervention that saves lives, then how is that also picked up in the change in quality of life that you would expect to accompany the person who's been removed from a desperate state?
Okay. I think I'm able. I think I'm going to start with answering the second question. So the first one, I imagine, is quite similar to Richard's question. Yes, there are studies picking up the difference, but not really making a comparison. I can think of one study actually. They do a kind of a scenario analysis or sensitivity analysis, looking at how when they switch the outcome measures. So instead of cost per quality, they use cost per event averted, and also change the time horizon and how that would affect the results in the end. So is it something similar to that, Gabriel, you just mentioned, to look at a different outcome? So not quality, but like, say, self-harm averted or suicide averted?
Yeah, well, I guess you could begin to get a bead on it in that way. I was thinking more about that, the interaction between quality of life and length of life, really, in that people who end up living longer as the result of an effective intervention in this sphere are also, to some degree, you would expect, benefiting from higher quality of life while they're alive. And whether there's anyone who's been able to pick up on that interaction.
No, not that I remember.
Okay, cheers.
Good question, Gabriel. So, any more questions from people? So that's been a really good discussion. Thank you, everybody. Some really good topics to maybe that we'll go away and think about and maybe pick up a little bit further in our discussion. So thank you, everybody, for those questions. So Fanyi, do you want to make any sort of final comments about the presentation or the feedback you've had from people?
Oh, I just want to thank you for all the comments and questions you raised, because some of them are just giving me new ideas about how to write a discussion point, a section which I'm doing at the moment. So thank you so much.